Everyone, and good to see everyone. So my name is Jayadev, and I am the clinical core leader for the ADRC. And so I'm just going to tell you a bit about the core itself, and I'll give you some basics about it. But feel free to ask me questions and throughout our conversation. So I want to just start off with really some of the very big basics, just to give some context to why we do some of the evaluations that we do. So broadly, the ADRC is interested in Alzheimer's disease and related dementias, which means that we study syndromes beyond AD, including syndromes that are sort of undifferentiated but lead to cognitive impairment. So the definition of dementia is that this word says acquired, and occasionally can be genetic, but a significant decline in more than one cognitive domain. So that means when we're talking about cognitive domains, we're talking about memory, executive function, visual, spatial. And so in order to be demented, one has to have more than one of these types of deficits. Otherwise, when we think about people that have mild cognitive impairment, sometimes they can have it just in one particular domain. We make that assessment that they have the significant decline based on subjective appraisal, so someone's inability to do things, observation by others, family members, physicians, et cetera. And then in addition, objective findings. So those would be like our biomarkers. Dementia, in contrast to, say, mild cognitive impairment, affects your independent daily functioning. You need assistance for just the basics. You're not working any longer, generally not driving, that sort of thing. And importantly, by the time that we are evaluating someone for dementia, we have to have ruled out that there aren't other causes for cognitive impairment. So things like pseudo dementia in the elderly there's a concern that depression can give people a phenotype of dementia, and it's really just depression. Use of substances, actually, I think I'm going to go over this. But anyway, so we'll make the diagnosis of dementia when we're certain that there isn't anything else going on. So this is what our typical assessment is in the clinic. So we interview the patient and the family or friends. So generally these people, when they have cognitive impairment, most of the time people come with a friend or family member. We first ensure that blood tests have been done, and often this is usually completed by the primary care doc before we see them, but we get blood tests to just rule out some of these medical conditions. So the typical tests that we do, and even actually we'll do in the clinical core as well, are checking for thyroid function, vitamin deficiency like B12, sleep apnea, which surprisingly can actually have significant changes in cognitive testing. We'll see that when someone we know has sleep apnea, then they'll go and put on their mask and then come back a year later and their testing is actually improved. So it can be a significant difference in cognitive scoring. And then, of course, medication side effects. So this could be anything from pain medicines or just sleep medicines, that sort of thing. And then, of course, there could be, you want to make sure there's nothing structural going on. There's this, I think it's This American Life, but anyway, so a story about someone who really looked like they had frontal temporal dementia, and really it's just a mass that was growing in the frontal lobe. In addition to that, medical history, we do a neurological exam, and I'll get into more of this later, but the neurological exam is important for a couple of reasons. One, you can find evidence of frontal release signs, so signs on exam that are suggestive of a degenerative syndrome. But then we also want to get a sense for whether or not they have something that could look Parkinsonian, or, for instance, ataxia, or amyotrophy, which means muscle wasting. Those are all clues that can sort of gear us or lead us to one potential diagnosis over the other. And then also in the sort of the primary initial clinic visit, Some individuals will get cognitive screening tests like a MOCA, so something really brief that they can do in the office and just determine if someone's, has something to be concerned about or is totally fine. So then let's say someone is in their primary care visit, and it looks like they actually do have something suggestive on their clinical evaluation that the primary doc says, maybe I need to get them seen by a neurologist. And so the neurologists then take it a step further, and they'll do brain imaging, which includes the MRI, and they can also do FDG PET. So that's looking at metabolism. So they'll look for regional changes in metabolism. I don't know necessarily how often people are getting amyloid PETs here. There are studies going on trying to get coverage for amyloid PET. Actually, I think it is covered now. But even in the absence of getting amyloid or tau PET, you can get some sort of functional testing. Then we will often send people to get detailed neuropsych assessment. So that's where we're having people undergo a couple hours of evaluation where they get really detailed testing of their language, their executive function, their memory, et cetera. And these are done by neuropsychologists. So people whose raison d'etre is to understand your cognition. And we'll get a sense there of what, again, sort of based on the domains, is there certain diagnoses that may be more likely than others? And then there are biomarker studies. And so those are continue to be right now lumbar puncture. And so we will, so often someone will come in with cognitive impairment. The question is it AD or not AD? So lumbar puncture with CSF can be helpful. We look for measures of amyloid beta and tau. And those two measures in relation to each other can fit a profile that suggests Alzheimer's disease or not. So low A beta and high tau together would be suggestive of Alzheimer's disease. And then again, you can have particular types of PET scans. So just to review a couple liners, and this may not, I think for this group, you may already have a sense of this, but when we think about these just in big broad strokes, AD, the most common cause of dementia over age 65, it seems to be more prevalent in females than males. I don't think we don't know why that is. If it's an epi thing or a biological thing, a combination, but there are more female than male. Which is important to people that are interested in using biospecimens like autopsy tissue to know that if you try to, if you're looking for brain tissue, there are many more females than males in the bank. It's roughly a 7 to 10 year symptom time course. And of course, those windows get larger as people start to appreciate that they're having cognitive changes. People get more sensitive to whether or not they're having cognitive changes now that people are more aware of AD and related dementias. So the cardinal features are insidious onset and gradual decline. So all of these diseases are slowly progressive. If there is anything that happens more subacutely, then you really need to think about other diseases. That being said, there have been a number of great studies looking at rapidly progressive dementia. And if you're talking about a group of people that are 65 and older, even in those people, when it's rapidly progressive, it still is most often by far and away a neurodegenerative process. It's just an unusual form of that neurodegenerative process. In individuals who are younger, then you need to think about things like autoimmune encephalitis or encephalopathy, other medical issues, or mass, that sort of thing, acquired forms of cognitive impairment. But in the elderly, even rapidly progressive disease is still neurodegenerative. The onset is typically memory predominant, and then with short-term memory, people can have language problems, difficulty with expression, and then later on can start to have they can have Parkinsonian features, they can have behavioral issues, they'll develop apathy, and eventually and can also have an increased risk for seizures. The genetics of Alzheimer's disease is interesting. So there are very rare forms of AD that are autosomal dominant, and we have always called them early onset familial AD. And so that's less than 1% of all AD. And the 3 genes that we know of are PSEN1, PSEN2, APP. They're nearly 100% penetrant. Beyond that, of course, is a huge field out there trying to understand what are other rare variants in families that cause Alzheimer's disease, as well as more common variants that in aggregate may sort of tip you over the edge or may increase your chance of getting late onset Alzheimer's disease. And those studies have been very interesting because it gives us somewhere to look for additional pathogenic mechanisms that contribute to Alzheimer's disease by, sorting out which genes are associated with a slightly increased risk. Frontotemporal dementia is another form of dementia that we are particularly interested in the ADRC, and so this work is led by Dr. Demoto Riley, who is an FTD expert. So FTD is the 3rd most common neurodegenerative disease, but it is the most common cause of early onset dementia. So that the age of onset is shifted earlier, and if you see someone in their 60s who start to have some cognitive change, you really don't really know if you're necessarily dealing with FTD or AD. In the very beginning, they can look similar. There are different subtypes of FTD. Different subtypes of FTD that have different courses. In contrast to AD, there is a suggestion that more of FTD is genetic, and as much as half of people with FTD have some form of family history of FTD-like, not FTD, but neurodegenerative syndromes. And then there is a growing number of genes that we know that are associated with FTD, and the most common cause being C9 or F72 gene expansions. So FTD, I mentioned that there are a couple of different types. So one type is behavioral variant FTD, and those are the people that are markedly disinhibited. They can also be apathetic. They can have strange oral and dietary changes, so eating a lot, like eating things that they normally wouldn't eat, sort of bizarre behavior, walking through restaurants and eating off of someone else's plate, changes in their own interest in self-hygiene. They can lose the ability to be sympathetic, and so that's often a complaint that family members will raise, and loss of being empathetic. And then there are the language variants, which can present with really prominent language changes without necessarily a lot of other cognitive changes. And in those where the cognitive changes are not so prominent, we think about FTD. If there are concomitant language and, say, memory changes, we might think about that as being more of a language variant Alzheimer's disease. But the language variant FTDs are primary progressive aphasia, and that can be non-fluent variant aphasia versus semantic variant aphasia. So these are the differences between these different aphasias, and actually we have an expert here in the group that can tell us more, are about what the language problem is. Are you dropping words when you're speaking? Are you not using the meaning of the word properly? Here's an example of an MRI with really dramatic atrophy of the frontal lobes. And then the imaging of these diseases can often be interesting. So different forms of FTD may have severe asymmetry to their atrophy, and depends on what type. They'll have left or right. The C9 or F72 variants of FTD often can have not the typical asymmetric frontotemporal atrophy, but can also have global atrophy and cerebellar atrophy. So those are sort of interesting additional pieces of information. Then there's Lewy body dementia, which is the 2nd most common. Again, similar slowly progressive disease. And Lewy body dementia is the umbrella term for dementia with Lewy bodies as well as Parkinson's disease with dementia. And so the difference between those two is really about timing of the timing of the motor features of Parkinsonism versus the cognitive dementia pieces. And so there's a 1-year rule where if you develop symptoms of cognitive change within a year of your Parkinson's syndrome, it's dementia with Lewy bodies. Otherwise, it's Parkinson's disease with dementia. And there is a significant proportion of people that have that develop dementia who have Parkinson's disease. It's about 25%. And this syndrome affects males more than females. So the core features of this disease, as opposed to memory or behavior or language, is, by textbook, visual hallucinations, fluctuating cognition, and then difficulty with visual spatial problems. They can also have REM sleep disorder, and there's a lot of interest in REM sleep disorder, even presaging dementia with Lewy bodies. They can have autonomic dysfunction, and then they may respond differently to some of the medications we typically use for behavioral problems with FTD. Vascular dementia is the second most common cause of dementia itself, and this is sort of a mixed bag in terms of risk factors. So you can imagine that sort of the typical risk factors. And I should mention, and I'm sure everyone realizes this, that these are all lists of different dementing illnesses, but in reality, people have a mix of a lot of these, especially with the vascular component. A lot of people have a primary neurodegenerative disease, but then have additional vascular injury that we see on pathology. So they're different. You can think about vascular injury in different ways. So there's small vessel ischemic disease. So these are the types of vascular injuries that are related to diabetes and hypertension and hyperlipidemia. And they can have more of executive dysfunction. They affect the white matter in the brain. So that's about speed of processing. Or people can have vascular injury from large vessel strokes. There can be deposition of amyloid beta within the vessels, and that leads to cerebral amyloid angiopathy, which is also age-related. ApoE4 is also a risk factor for CAA. And as an aside, people that have ApoE4 and CAA also have an increased risk for having these inflammatory reactions to CAA. They can present rather sort of acutely with flare changes on their brain and inflammation and sort of an episodic process. Here's an example of some brains. Let's see. Oh, okay. So the clinical presentation of vascular dementia I mentioned already. So there's reduced processing speed. They have difficulty with working memory, executive function, and they too can have significant apathy, depression, emotional blunting. Here is a brain MRI with pretty prominent small vessel disease. Let's see, where am I? There we go. So you can see these white matter changes, periventricular white matter changes. These are all in these small, in these tracks that go from the gray matter down to the deep gray. And then here is an MRI series that's trying to identify blood. And so these little holes here are examples of microhemorrhages. And you can see they're sort of in the cortex as opposed to being here where they would be if you had, say, hypertension. This pattern is typical for cerebral amyloid angiopathy. Okay, I realize that I'm need to move on. So here's an example of a brain MRI. This is a healthy, so there's a coronal section of someone's brain. So these are the hippocampi. And you can see in an Alzheimer's disease, you compare this brain to that brain, the ventricles are a little bit larger because there's some atrophy, but also you can see this hippocampus is smaller than this guy. Okay, so what are we doing with the clinical core? The idea is that, so here this purple line is a progression of someone's cognition. And on the y-axis is ability, and on the x-axis is years. And so we know that people start with some capacity, and then over time they start to go down, and then eventually as you get to a certain level, you're dementia, and then if you're in the middle somewhere, you're MCI. Now, prior to even changing clinically, there is this slow accumulation of Alzheimer pathology. The idea being that this is all collecting even before you even have any obvious changes. And so one of the goals, if we can't get rid of it, one of the goals can be, can you at least decrease the burden of the neuropathology? And this is really just a proxy. Can you just decrease the pathological load, and then bring this cognitive change to be a less dramatic decline? And can you prolong the preclinical stage, even if you can't get rid of the Alzheimer's disease pathology itself? So some of the considerations and challenges in addressing Alzheimer's disease progression is that, first of all, the disease-modifying therapies, like some of these antibody treatments, clearly seem to be most effective when started on people that are earlier in the disease course. And that seems to be borne out both in the late onset sporadic AD as well as in the early onset familial AD. So identifying people early is really important. So how do we do that right now is through the lumbar puncture or through these molecular PET scans. There's a lot of effort trying to get biomarkers, reliable biomarkers with blood, and that seems to be coming. So the purpose of the ADRC, really, in broad strokes, is to do a longitudinal study to establish the clinical course and establish multimodal biomarkers that may be happening before clinical onset or early. So here's the clinical core, the ADRC clinical core. So there's myself, Kimmy DeMotta-Riley, Robin Lawrence, a number of clinicians, and then we have a group of coordinators that do both of the evaluations as well as organize all the visits. And we have a manager who helps Melanie Burke, recruiter Teresa Keene, who is actually located within the clinic. And this is an important person. Teresa actually visits with people when they come to the clinic and tells them about the clinical core and the ADRC, and has that sort of face-to-face introduction and invitation to the core. And that has been remarkably helpful for people to get more comfortable with the idea of committing or joining a longitudinal study. And then we work really closely with our DMS core, a data management core, and you'll see a graphic of how that works. We're sitting there in the 14th floor of 9th and Jefferson. Now I'm going to just give you a sense of the aims, and we're going to be going into a renewal. So these aims are going to evolve a little bit as we in the next coming months. But basically, the idea is that one of the aims is to clinically characterize longitudinally, promote the better representation of underrepresented groups in ADRD, really focus on our cognitive characterization so that we can use methods that can be applicable or at least harmonized across centers, because different ADRCs don't all use, some of the testing we do is all the same. And then beyond that, ADRCs will have their own special testing that they do. And lastly is obtaining biomarkers to support great work that's going on. So some of the phenotypes, the biomarkers we get, so there's psychometrics, which you would get in the form of data. There's pathological tissue that you get from the neuropath core. We have an imaging biomarker core where we're getting MRI, and now we're getting amyloid PET and tau PET on some cases. We collect DNA on everyone, and ApoE4 is genotyped on samples at different stages, but it is available in some individuals. And then in a few individuals, there's actually more genetic data, which includes SNP data, and a few cases have exome data. There are also some individuals in which we have PBMCs and skin samples. Here's a breakdown of the core as it stands, and this is sort of gross, but so one of the interests of the core is to study resilience to disease. And so we, during life, the way we identify this is people who are over 85 but still with normal cognition. They seem to be doing better than most. We have 145 controls that do not yet have any cognitive impairment. We have more folks with AD than MCI, so 82 MCI. We have 37 people with FTD, and then a few others that either haven't yet been differentiated into a particular syndrome, or includes individuals with DLB or PTSD. This gives you a sense of what an ADRC visit is, and so it's usually a couple hours. So a participant and a co-participant come in. Everybody has to have a co-participant, so there's some sort of collateral information. Generally, they come in together. They don't always have to come in together, and they get consented. And that actually takes 30 minutes because we need to explain to everyone rationale for the study. They are giving us a fair amount of personal information, so we need to let them know about the risks of giving that information, and then tell them how we store that information and how it's protected, as well as a discussion about the potential biomarkers we may ask them about. In the visit itself, we get information about health history, family history, social history, which includes things like smoking, alcohol use, etc. There are other parameters that we're hoping to include, and that includes things that would give more information about the social determinants of health, and we're building that out right now. And then there is cognitive testing, which is similar to what I mentioned at the very beginning, which is testing different domains. There's a neurological exam, again, in order to give some clues about if we're dealing with Alzheimer's or are we dealing with some sort of Parkinsonian type syndrome. And then there's a blood draw. At the same time, or at a different, in that same visit, we talk to the co-participant to get some insights from that person's perspective about whether or not they think this person's having issues or not. Here is just a breakdown of what this uniform data set. So everybody in the clinical core gets evaluated once a year with this type of visit. And in addition to the physical exam and all that history, they get this uniform data set, which includes all these particular questions. And these, in addition to the neurocognitive testing, there's also some of these other questions that have to do with your functional abilities. There is a standard survey that asks questions that supposedly are about depression, and we ask those too. But this is sort of a survey, a list of all the different things that we get from people. So after we fill these forms out, the clinician has a gestalt about what's going on and writes that down. And then every 2 weeks, we all meet as a group and we go over the data, the conversation that the clinician and the psychometrist had with the patient, the co-participant that day. We discuss that, as well as the results from their neuropsych testing and the physical exam, and then we come up with a consensus diagnosis. Neuropsych testing, I think I've discussed already, is a number of different domains, and so people will get specific tests with those. So that's the clinical exam. And then so to give you a sense of what's directed our clinical core recruitment, right now, what has led to the cohort that we have now is trying to recruit to support certain research themes that are happening here at the UW, which includes interest in the heterogeneity of the biological mechanisms of AD, interest in resistance and resilience to AD, and then recruitment and engagement of American Indians. And so that has really motivated our recruitment until now. I'll show you in a minute. We also have now, this past year, been able to recruit additional cohorts. If anyone's interested where folks are coming from, this is the map. And so here we are at the clinical core. The ORE, the Outreach Recruitment Education Core, at this time really helps us to recruit underrepresented groups. And so these are people from the Latinx or Latin community, urban American Indian, as well as we have interactions with tribal American Indian, Alaska Native. But these folks here from the Latinx group and urban AIAN are recruited and welcome to join the clinical core directly. And then there's ORE InReach. And so these are folks that have been more the folks that traditionally have come into the core. These are people that are most often coming from a memory brain wellness clinic. And the people that come into that memory brain wellness clinic themselves often come from the UW or the WAMI region. And then to some degree, they're coming from outside, like Swedish and BM, et cetera. So the InReach piece has been very helpful as we try to bring in, like I said, earlier stage disease folks. And so if people are coming to the memory clinic, there's a question about their diagnosis. And this is where we find people who are just getting the diagnosis of MCI, mild cognitive impairment. And so at the Memory Brain Wellness Clinic, they see more than 1,000 new patients a year. And so through that InReach, and like I said, Teresa Keene goes out into the clinic to meet people and tell them about the clinical core. Through that, we recruit at least 25 people a year that have MCI. And then over the past year, thanks to the efforts of our core, ORE cores, Drs. Koh, Buchwald, and Johansson, we've been able to massively increase the recruitment of Latinx and AIAN. We now have at least 20 individuals, 25 individuals we've recruited from both cohorts just in the past 6 months, actually. And we anticipate that to continue because I know there's some people that are interested in diverse cohorts for their research, and so we're hoping that we can help support that. If you are interested in engaging the clinical core, there are a couple things that you can think about. So one is, contact us if you're interested. There are ways that we can give you information about how many people fit your research question. In fact, we were just looking at that dashboard the other day. You have your own IRB. We ask that if you are interested in recruiting from the core and getting information from the core, that you include in your IRB or consent form that people are willing to have information from the ADRC sent to you. And once they agree to that, then we can share all the information we have with you as well. And then we'll give you a list of participants to study, and then you can recruit them. And again, there may be other pieces of information that are not in that UDS set of data that we may also be able to provide depending on what your interest is. And again, you can also request biomarker data associated with those individuals. So our model of CC funding for studies that are interested in recruiting significantly from the core and would like our help to reach out, recruit, schedule, that sort of thing. These studies do support some small FTE for some of the coordinator services that we provide. So if you have any questions, email me anytime, and we can talk further, and I can point you to where you need to go to get the resources you're interested in. All right, so now I can, if anyone has questions.
Any questions out there? Pretty clear to me, but I think Andrea's got one. Go ahead.
Oh,
Yeah. Hi, can I ask a question? I was a little bit familiar with the work. I didn't realize that the logistical and coordination burden the clinical core has. So I'm really surprised by how well it's been running. I was surprised because I also didn't know about the outreach system, and it's surprisingly well developed.
Surprising what, sorry?
well developed.
Yes.
Some of these communities like Latinx, American India, and Native Americans are really hard to reach. And I was surprised, and I was wondering if you could tell me more, because these are communities that we have been trying to reach for other reasons,
Yeah.
unsuccessfully for a long time.
Yeah, no, and these are really amazing efforts from two groups that have been investing many years to do this. So Linda Coe, who has had a longstanding interest in health disparity and diverse population research. And so she is the leader of the core. And so they have already an established relationship with the Latinx community. And so one of the ways that we've recruited is that we've gone out to, so we will go out to some of the educational events, or they'll have health fairs on weekends, and we talk and let people know about the core. But then also through Linda's facilitation, we have been able to recruit during these events as well. And so that, I think, is the main way that we've been able to make contact with that coordination, is because Linda has established the relationship already with that group. The American Indian, Alaska Native group, similarly, Deidre Bookwell has been working with that group for many, many years. Specifically, this last round of recruitment we have is actually through in collaboration with a study run by someone called the Urbane Study. And so they're interested in urban American Indian Alaska Natives. And so so these folks are not necessarily tribally affiliated, but similarly, we've gone out and joined, they've invited us to come and talk about AD and talk about dementia, et cetera, in that community. What I didn't mention, so that's how, I mean, it's through collaboration with people that have put in the legwork and the time to make those relationships. And one way that we think, at least what we would like to do, is to take then the next step and make it also worth their while to spend time with us. And so you saw that the InReach group, they're already seen at Memory Brain, the MCI people, they're referred, anyone who's hitting a tertiary care center has some health care in place. But one of our goals for the coming 5 years, as part of our specific aims, is going to be, we'd like to continue with these research visits and then be able to give some clinical information back to people, especially if they don't have, they don't necessarily have a dementia doc, but can we give them something of use? Can we make relationships with their primary care doctor? Can we provide some support that may even be able to help them find healthcare in their local area, if they don't already have it? And so that's going to be one of the goals going forward, is to give value back to participants. And I think we're going to have some exciting changes coming up this year with the ADRC that's going to facilitate that, from some people who also, it's their research and clinical interest is to expand research and care into rural areas. And so I think that's going to be really exciting.